our session today, Eswatini Hospice at Home. My name is Symptom Palliative care nurse here at Eswatini Hospice at Home. My apologies, in the agenda there is 7 in Kambole, but today I'll be taking you through, I'll be facilitating this session. You are welcome. Everybody that has joined in, you are welcome. I want to say thank you for joining in. This is our eco session, extension for community healthcare outcomes. Yeah, we are working towards building capacities and bringing gaps in the areas of healthcare. So as you join in, I would like you to introduce yourselves through the chat box. You simply write your name, your facility, and also the role that you are playing in your facilities. So today's session is artificial nutrition and hydration, ethical dilemma. So our ground rules for today, the first one, I would like to let you know that we have to switch off our laptops, our phones, and mute also. Then we have to unmute when speaking or commenting or asking a question. So let all this be unmuted so that we can all get what is going to happen today. Then we respond by raising your hand or indicate your response on our chat box that is available on our screen. So every comment we will have to look at it. If you indicate there in our chat box, but if you want to comment by speaking out, you raise your hand so that everything can go smoothly. So as we continue, we would like to start our didactic presentation on artificial nutrition and hydration ethical dilemma. It will be presented by our sister Felicity Lukele from Babane Government Hospital Palliative Care Unit. So thank you very much. I think Ms. Felicity is ready to take us through her presentation for today. Sister Felicity, are you ready for our presentation?
Hello, am I clear?
Yes, sister, we hear you.
Okay. Good day, team. My name is Felicity Lukele. I'm a sister here in Babane Government Hospital at the Palliative Care Unit. The topic for today is ethical consideration on palliative care. Ethical dilemma, nutrition and hydration. Right. Okay. Sorry, I'll be looking at your screen. Objectives for today: to prepare healthcare workers to discuss, record, and honor individual choices about artificial nutrition and hydration. Identify advantages and disadvantages of artificial nutrition and hydration. We'll use the A, NHS for artificial nutrition and hydration. Okay, to demonstrate understanding of factors and influences that can, sorry, I have a problem affect decision on ANH, to explain ethical consideration in ANH. Give me the slide. Next slide. Hello. Can I have a next slide?
They have it up.
Next slide.
Yes, it is on the screen. It is coming.
Yes, can I have it? Can you send through the slides for me? Next slide, please.
Are you okay now?
Yes, you'll be sending me the slides. Is this the second slide? Yes. Introduction. A fundamental caregiving task is to provide food and fluids. Nutrition and hydration, symbol of care and compassion. Eating, symbol of health. So when you are healthy, when I care for you, I can show that by giving you food. So when I say I'm giving you that food, then it's showing that I care for you and I'm really there for you. Then technology of ANH, specifically with temporary medical problem. So that was just a problem to solve a temporal medical condition, like they will use it on the post-gastric motility issues, when there's a swelling issues, impairment following a stroke, or a stroke in a patient with good prognosis. So they'll use those artificial, but however, even with patients have been widely, it has been also widely been used in patients with very poor prognosis and for those with likely functional abilities. Few decisions are more value laden than those to withdraw or withhold a medical intervention is thought to be able to prolong life. So this artificial was only used for those with those temporal, then later for even with those with poor prognosis. Factors influencing the ANS decision making. All decisions about the use of any medical service or treatment should be based on the patient's goal of care, the medical need, and the burden and the benefits of the treatment. The patient's rights to withhold or withdraw ANH if the burden or risk weighs the benefit. All ANH decisions should be made in the light of the patient's goals and customer and outcomes of care, Patients and family members' deep concerns about the use of hunger and starvation. So when we come, ethical consideration on ANH. The question is whether or not a practice, treatment, or intervention will restore or enhance the quality of life for a patient for a particular patient. Before you decide a yes or a no, but you should also look at the best medical and clinical practice. Is it you have to look at the ethical consideration and also the major additional cost considerations, because the NH also comes with a cost. You have to do something is never a justification for artificial nutrition. Weight loss and dehydration. Weight loss and wasting in advanced cancer is nearly always due to cachexia syndrome caused by changes to metabolism secondary to the cancer. Never responds to internal or parental nutrition. Internal nutrition is also associated with side effects. For example, infection. Effects of dehydration in terminally ill patients, dry mouth. But this can be well palliated topically. When the dry mouth is, you can apply some mouth moisturizer or Vaseline, or just a drop of water on the mouth. Thirst, although dying patients do not complain of thirst. We assume they must be thirsty, although they never say you are thirsty. Okay. Diminished conscious state. Several reports and single randomized control trial showed no correlation between dehydration and cognition in these patients. They are just there. Artificial hydration. Possible benefits of dehydration in a terminally ill patient. Less urine output means less movement and less incontinence. 2, less pulmonary secretions, reduced dyspnea and terminal congestion. 3, less gastrointestinal secretions will lessen nausea and diarrhea. 4, less problem with edema and effusion. Possible disadvantage of artificial hydration in terminally ill patients may have opposite effects of the benefits of dehydration and worsen the patient's conditions. The advantages which I've just mentioned may give ambiguous signal or false hope to the patient and family. Drips act as a physical barrier between patient and family. Dehydration in patients which are not terminally ill. So the effect of the dehydration, it will cause thirst, dry mouth, and postural hypotension. Patients unable to take or retain adequate fluids warrant parental rehydration. So I thank you for the presentation. Sorry, I lost some things along my preparedness here on my screen, sorry. So this is where my presentation ends.
Thank you, Sister Felicity, for an informative presentation. I would like to open this room for anyone who may have a question or anyone who may have a comment as we go through this. Okay.
Just hello.
Yes, Sister Felicity.
Just to add, so as we're going along with the family towards the end of life, I think it is very important to prepare them that there will be a time whereby there'd be no need to rush the patient to hospital, so that just for an IV drip, because most of the time you say she has not been eating for some time, so maybe a drip will boost that patient. So we have seen some disadvantages of this parental feeding, and some of these parental feeding are very expensive. So you might be giving them to a patient with poor prognosis, yet there is this one who is post-operational procedure and has a good outcome for receiving the artificial feedings.
Okay, thank you. Thank you, Sister, for the addition. Mr. Mabuza here has a comment, so I'll give the floor to him, please. Mr. Mabuza.
Good afternoon, everyone. My view is to say thank you to Sister Felicity in the clarity of in the classification of the benefit of a terminally ill person, the hydration benefits of terminally ill patient, and who is not terminally ill. I think that one will help us to explain clearly to our caregivers in case they rush to hospital wanting this hydration too, so that they can know what are the benefits of this thing and what are the effects of the hydration to the patient, more especially if the patient is at the end of life stage, so that the relatives can have a clear understanding of what the impact the procedure or whatever intervention is going to bring to the patient. Thank you very much.
Okay, thank you, Mr. Mabuza. I think this is a very, very, very important point, especially the patient here is the major decider, and it's an important decider as well as the caregiver. So it's very, very important to explain and to let them decide, to let them make a proper and informed decision making for everything to go smooth. Thank you so much. Is anyone who is willing to comment? Anyone who is willing to ask questions about this presentation? You can raise your hand or write on the chat box if you have got any comments about this. Thank you so much. We will proceed with our session here. We move on to the case presentation. Unfortunately, the Tlhatikulu Government Hospital did not make it through the case presentation. So Eswatini Hospice at home will be the one who will give this case presentation, and Mr. Mabuza here is going to lead us in the case presentation for today. Mr. Mabuza, the platform is yours, sir.
Thank you very much, Mr. Kere. We are going to take a look at our case for today. Okay, our case is a 70-year-old male who suffered from severe stroke, who was on this day, it's a follow-up case. On this day of the complaint, our patient was at the end of life stage. He presented with signs of end of life stage during this day of assessment. When there was, okay, what the main problem or concern here, the carer, who is in this case the wife, wants us to put drip on the patient and an entry tube because the patient food intake has severely decreased. He only takes 5 minutes per minute. He is feeding with a syringe. And my concern is that the intervention will not help to improve or change the patient's prognosis. A chief complaint: the loss of appetite since 3/7. So it's 3 days back, no activity for two days back. The patient assumed one position unless told by a caregiver. The patient does not forward any complaints anymore. He used to wake up at night and feed, but does not anymore. Surgical. The patient was diagnosed with hypertension for some years, and later, 2013, he suffered stroke. He was in and out of private hospital for control of symptoms after he suffered the stroke. There is no past medical medication that we were able to obtain. Currently, the patient is on HCTZ 25 mg or TPO. Social and history. Work status. Our patient is a retired high school teacher and educationally tertiary, socio-economic, in the middle class, mental status. He's married with 1 wife. Lifestyle habits: no alcohol intake, non-smoker, or any other harmful habits were noted. Relevant health conditions in the close family members. His siblings were also diagnosed with hypertension. Unfortunately, he's the last one. They are all gone. Advanced care directive. Okay, our patient did not have any advanced care directives, and he did not have any living with. So the advanced decision to refuse treatment, there was nothing available to refer to. And a healthcare proxy, in this case, is the wife, because it's the one who is close to him and he's the carer. So he is the healthcare proxy for our patients. Mental capacity assessment, yes. And the patient was not mentally capable of making decisions on this day of assessment. Review of system. We have a BP is 103/69, pulse 79, my respiration 17. So sorry about that gap. We do not have that equipment for measuring the O2 saturation. And the pain score of this elder patient during this day of assessment. The patient did not complain of, did not forward any complaint, which means there was no pain. And the functionality status, it's 4, ECOG 4. And the review of system, pain was 9, dyspnea was moderate, anxiety was none, agitation was none. Depression was mild. Drowsiness and fatigue was mild. Nausea and vomiting was none. Anorexia was 4, because the patient was not eating anything. Constipation, it's none. Dry mouth, it's 1. Poor mobility, it's 4. The patient was not able to do anything. It was sitting in one position unless tended by a caregiver. Focus investigation, the only investigation that we obtained from these past medical records, HIV records were negative, and that is the only medical record that we were able to obtain from these papers from medical records. And further plan, here we have to discuss end of life care with the family members, who is in this case 2 sons and a wife who is the carer. We take them through signs of end of life stage, to support them where I can, and engage a spiritual advisor in this case is a pastor, because our patient is a Christian. The symptom control, maintain skin integrity so that the patient cannot develop any sores. Bathing the patient, maintain a clean environment, dry environment, try to improve comfort of the patient, priority at the end of care life, and to improve the comfort of the patient. Unfortunately for our patient here, it's very sad that our patient, soon after the assessment, our patient expired. So we couldn't go back to do another intervention, but a family meeting was then discussed, the end of life of care and control of symptoms, so that our patient could die in a comfortable manner. I thank you.
Thank you so much, Mr. Mabuza. It is so unfortunate that our patient is passed on. Condolences to the family. And it is so unfortunate that there was no care directive planning, but we hope the family discuss this matter, and I think everything will go into order as they proceed with their bereavement period. So is anyone here who has the comment and recommendation? We are hoping that others are still coming. But if anyone here who has the patient, please, you may raise your hand or indicate on the chat box provided on the screen. I see a hand from Sister Felicity. Sister Felicity, I see your hand. Is there anything you want to say?
Yes. My concern is that most of the clients, they don't have this advanced care plan. So that is why some relatives say, please get a drip, will make better. Yet some patient might have not wished to be resuscitated. As some of the supporters, caregivers, they believe that by giving the drip, you'll resuscitate. Yet I know that it's the end of the disease. So my word is that how can we motivate our clients or educate our clients to have the advanced care plan being prepared before they reach that stage where they cannot decide on their own?
Thank you so much, Sister Felicity, for this. Sister asked that about this care directive planning. It's how can we best motivate our clients for this procedure? Is anyone, Mabuza, can you share?
Okay. Thank you, sister, for a very much important contribution, because we are seeing more and more of our caregivers or our proxy decision makers sometimes wanting coming to facilities, wanting drips or feeding tubes for our patient, but it is a very difficult area, and it's in our culture. When you go to a patient and you speaking about that, it's very much sensitive. But I think it's something that we can try. Maybe it's unfortunate that our patients, they are referred to us mostly at the end of that stage, but it's something that you need to be confident as a health provider with knowing the story and knowing what you are saying to the relative and how it's going to benefit the patient. And you have to remember beneficence and non-beneficence. I think it's one of the things that you have to bring up to boost your confidence, so that you can explain clearly to our patients that these are the things that you need to consider. Because you become immune, there are things that you do not want, and there are things that they may bring up while we are ongoing with your treatment, with your especially our terminal inpatient. So I think taking into account the advanced care directives, it's one thing that needs confidence from us as healthcare providers, because it's not an easy task to talk about that, because our patient will think that we are talking about them. Yet here we're not talking about that, we're talking about what in case you cannot communicate to us, you are not dead, you cannot communicate to us. What would you like to happen to you? Would you like maybe blood transfusion, or you explain, not that you want to, because some patient, when you speak of not talking, you will take into consideration that no, I'm going to die, but that you must try to explain to the patient, no, you are not dead, you are alive, just that you cannot communicate your wishes to us as health provider. There are some procedures that our patient, they will not like to be done on them. So I think we need a confidence more than anything to be able to explain to our patient about the advanced care directives, because it becomes an issue when you see a patient, the family member advocating for this intervention, yet it is not going to help the patient at all. So I think that's something that we need to consider. And bottom line, I think we need the confidence as a healthcare provider to talk to them about that thing to our patient and relatives and the carers and the carers, so that the patient will be aware that we are not talking about that, but we are talking about a treatment while he is still alive, not what is going to happen after he is dead. Thank you.
Thank you so much, Mr. Mabuza. Sister Felicity, were you answered?
Yes, thank you so much. Clearly understood.
Okay, thank you so much, sister. I would like to give this opportunity to Mr. Mathango. There's something he wants to comment on this, Mr. Mathango.
Yes, thank you so much, Mr. K. Another thing, Sister Felicity is raising an important point. We may not sometimes blame the relatives when they come with these demands of age, wanting to be fed artificially, wanting the artificial hydration for their loved ones. And most of the time, they don't need this when the patient is still okay. They demand this from us as health workers when the patient is now unable to make decisions. I think the things that we need to write on as healthcare workers on helping our clients and their families to have these advanced care directives. It's a good, it's a serious issue, especially in our country, that we need to look closer in terms of helping our clients have advanced care directives. Because we need to do that, start those conversations about advanced care directives at the public health facilities. We need to start there when the patient is still alive, when the patient is still okay, when they are stable with a lower equal functionality status, 0 or 1. Because normally we know that these life-threatening conditions, they then tend to become life-threatening and they are progressive, most of them in nature. So there is always a guarantee that if this condition is not well treated therapeutically, it might progress to end of life and then death. But we wait for the time when the patient now is approaching death for us then to begin to bring this conversation. I think that's how the door, and that's how most of our cases, they will appear, no advanced care directives, no living with, because we wait until the worst happens. I think we need to move those conversations. If it's in a ward, just the admission papers, the admission files, has to include this space. They should be updated or contextualized so that they accommodate an area where the patient, while still admitted alive, if while you are still stable, didn't make a living will or an advanced care statement, can be given the opportunity to nail down their advanced care statement. Sometimes that's an opportunity for them to decide and say, okay, during this time of my condition, should I not be in a position to make my own decisions? These are the decisions you can build on. And then the issue of thorough education on our side, I think we need to do that on admission. If I made the nurse admitting or the nurse seeing this client, I need to cut across, even when I'm breaking the prognosis news. That's okay, based on this diagnosis now at this stage, this is the prognosis. And then state the importance of the advanced care directives, because advanced care directives, they may not be that difficult like a living wing, because they are easy, because the patient can mistake them now, he can even nominate the process decision maker at that point, which will guide us as healthcare workers to know this patient wants this and this patient will not like it. I think that's how we can spare even their lives. But sometimes they are unable, the relative, to make the decision of, okay, we will continue the artificial hydration and nutrition at this point. They don't know the effects and advantages of it. Sometimes I feel like as a worker, we give them a candy package. We like to decorate everything that we have without even telling them the side effects of it. Sometimes we will give them the side effect, they will say that we are withdrawing the treatment from them. But I think after complete information, giving them the whole information that they need, so for them to make an informed decision, can help us to escape the issues of them being pushed to facilities, forced to take this artificial hydration and nutrition. Thank you, Mr. K.
Thank you so much, Mr. Matlawo. That was a very informative recommendation. Sister Felicity, you are still raising your hand there. Is it by mistake or is there something else that you want to share with us?
Sorry, it was by mistake, but now something has come to my mind. I had to remove. Can I also state that in most cases, these enteral and artificial feeding are so expensive, such that they are out of stock sometimes, these feeds. Or they cost the family to have a blender, something to make this feed so smooth, and find that some families do not have those kind of things to use at home. Even if the patient has that empty tube, is likely to develop some infections at home. As we know that sometimes the tube is not securely placed. It just moves as they are using the feeding tube. And in hospital, these parental feedings, they use the central line, of which is one of the very major blood vessels to feed for the parental. And infection for there can lead to severe septicemia. And even our nutritional dietitians, sometimes they say they don't have the stock to feed those patients. Actually, even now with the budget, when they have a stock, they just tell me, we don't have stock for patients for palliative care, but we do have stock to give those post-operative patients. So we really have to educate them and clear state that them that this they might not benefit with those. Actually, they are not even budgeted. They are not included in the kind of the budget. They don't include palliative patients. And with this NG tube, even though they can go to somebody who can put in the NG tube for them to feed, it exposes so many infections. Sometimes the tube moves out of good place, and with the hygiene at home, there might be an infection being introduced to the patients. Thank you.
Thank you, Sister Felicity. We are very much grateful for this, for the successful session. Thank you for so much, everyone who have participated. We are very much, we appreciate your participation. We appreciate your presence. So we would like to, I say, about the feedback session. Yes, it is very important and valuable to us. And as I mentioned earlier, that this platform is so beneficial to us, because we are working towards building our capacities, and we are able to bring in, we are able to close gaps in everything, in the areas of healthcare, in the areas of education. So it is very important for us. So is anyone here that I am leaving behind? I see in our midst we have Simkwe Damini. Is there anything that you would like to share before we close this very important session for today? Thank you so much. Thank you so much. I see you have indicated on the chat box. Please, colleagues, there is a link there. You log in the link and give us the feedbacks, your feedback about this session. I think we have come to the end of this presentation because the recommendations, Mr. Mathango has already brushed on that. So our next item will be on the feedback, sharing information and announcements on the next session details. We'll give this time to Mr. Mathango.
Yes, thank you so much, everyone, for participating in today's session. It's indeed a busy week for everyone, and we appreciate your presence. And we believe this today's session will benefit us, especially in supporting our clients and the patients that are under our care. Let me just encourage and say this past weeks we have been looking around the ethical dilemmas that are revolved. So we are picking those instances where we have ethical dilemmas as healthcare workers so that we can make decisions. So we're empowering one another on how to deal with these issues where we have dilemma, when I don't know whether I must disclose or not, whether I must talk about the advance care directive or withdraw. We were discussing that one in our last session, and today we are saying there are these other ethical dilemmas that include artificial feeding and hydration. But I don't know, is it okay to give or not? What we want to say is that in palliative care, we discourage the issue of saying, I'm just doing it for the sake of saying I've done something. We don't go for that and say, okay, I'll just give you the food, whether they will benefit you or not, just to ensure, to prove to you I've tried something. So we always prioritize the patients and the goals of care. So let's go out there, sit down with our colleagues, let's prioritize the patients. Let's do that assessment and see if this patient, whatever treatment we are giving the patient, is it still going to benefit the patient? What are the how much are the outcomes or the benefits against the negatives? In Sister Felicity's presentation, he finished it with the advantages of dehydration. And then he also talks about the advantages of hydration. So you can see that we need to balance these two always and find out, is it still feasible for this patient? Am I not pushing the patient to something that will cause more harm than the outcome? So I think in that way, we are going to be able to give our patient comfort with the knowledge that palliative care is not only about life and about dying or about life only, but it's about both. When I'm still alive, I deserve the best quality of life. And when I'm dying, I deserve the quality of life even when I'm dying. And the quality of life is defined not by the health provider, but it's defined by the patient. So that would be my input for today. And otherwise, and then encourage Mr. Mabuza to ensure that he continue to provide bereavement support to the family, because sometimes we neglect our patient after they've lost their loved ones, yet it's when they also still need us to continue with bereavement and support after our loved ones is left this way. Concerning our next session, let me encourage that we also click on the feedback link. It helps us as a team to continue to give you the best sessions that you may need and information that will take us far as a healthcare system. And also, let's announce that in our next session will be on the 6th of April, and we will be looking at another ethical dilemma that we usually face, which is an Indonesia versus palliative care sedation. So we'll be looking closer to that interesting topic, that how to deal with those issues where Indonesia and palliative care sedation looks alike in the eyes of a patient or a healthcare worker. And then we will be meeting at 1300, same time. We encourage you to invite others to join so that we can influence the country and change our health system together. Thank you so much. Thank you so much, Alina, to clarify the date, 6 April, and the time 1 p.m. Standard Time, South Africa. Thank you so much, team. May I hand over to Mr. Kelly?
Thank you so much, Mr. Mahlangu. That was a very informative session we had today. We hope the same for the next session, which he just announced. It's a very important point that Mr. Mahlangu said. Please invite others so that we only cannot benefit, but others too. Because our main goal here is for caring of our patients, so that they can be provided with special care. We need to get this. We need to have this as healthcare workers. We need to capacitate ourselves with every information that we have. So let us invite others to join in for the next session. So thank you very much. See you next time on the 6th of April, 2022.
Bye.
Bye. Thank you.
Bye, bye, bye. Thank you so much. Thank you, Mr. Sandley. Thank you, everyone.
Bye.
Where is he?
Bye-bye.